Welcome to Mind Over Matter, and today it's a pleasure to welcome David Rochefort, who is a professor of political science and public administration at Northeastern University, having a particular interest in mental health care in Massachusetts, and author of a monograph with the same title. And that pretty much is what we're going to talk about today. I think I'm looking forward to this, actually, because I think you have an opportunity to look at the system from the top down, and I have an opportunity every day to look at the system from the bottom up, so it'll be interesting to see where this goes. But let's talk about the lost vision and the whole scenario of mental health care in Massachusetts.
Thanks. Well, first of all, thank you very much for inviting me and giving me a chance to talk about this research of mine. I think it is important that there are two, at least, visions that one could take on mental health care in Massachusetts, from the top down, from the bottom up. And I think the idea of the vision and what's happened to it is a key issue in understanding the course of the system. It seems to me that there is quite a strong vision, actually, for what the mental health system should be doing and where it should be going. And that this vision has to do with the long-term movement from a system that's been centered around state hospitals, long-term hospitalization, and moving in the direction over a period of decades toward a community-based system. And I think that's a clear vision. I think that's been in mind quite clearly over a period of decades, no matter which political party is in power and who happens to be holding which administrative seat. But I think what's become clear over time is that it's quite a difficult vision to realize completely, and that it really requires ongoing commitment. Severe kinds of budgetary issues come before you when you're trying to realize this vision. And I think it's not so much that the vision has been lost, as that we need to continually recreate it. We need to find out what are the next steps, how do we fund this, and how do we make the necessary commitments.
Now, who's we, though? I mean, whose responsibility is it to see that after the deinstitutionalization, which is where a lot of it began, the balance of community-based programming was in fact put in place?
Well, I think it's a responsibility that's a political responsibility, but it's a social responsibility as well. We know that stigma is a major factor affecting the way that we view the mentally ill, and affects the level of support that the public gives to political decision makers on this issue. So I think it's a broad-based responsibility, but clearly those who have positions of power, those who are able to move political resources in one direction or another, have to understand what the key issues are, and they have to make the commitments necessary.
Okay. And your definition of key issues?
Well, I think there are so many. There really are. When we talk about the system of mental health care, it's really a non-system, that there are different sectors that operate, with linkages across and between, but not in a well-coordinated fashion. And so we can talk about issues like managed care and the way that has affected so many, both in the private sector and in the public sector. We can talk about insurance coverage and the recent passage of a parity insurance bill in Massachusetts that was unfortunately only a partial parity bill. We can talk about issues like homelessness. We can talk about children's mental health services, which right now is perceived to be in virtually a crisis situation. So I think there's no shortage of issues to discuss here when it comes to looking at the current state of the mental health system.
But there is again, with the non-system, I mean, there is a shortage of people who sort of look at the whole picture. So that really in the advocacy community, there's a tremendous amount of turfing. So that I think a lot of the advocacy groups have kind of neutralized one another, because one will fight for children, one will fight for adults, one will fight for acute care, one will fight for care for the long-term mentally ill, et cetera, and there's very little coming together in a planning way, so that the various pieces get looked at as part of a whole.
I think that's true. I think that's been the case for a long time, and I think that these different constituencies do have their points of view in the system, and certain populations that they have in mind more than others. I think it's also true that the fragmentation is replicated, if you will, when you look at the organization of the bureaucracy, that there are different kinds of categorical functions that are assigned to different bureaucratic entities, and that furthers this fragmentation. You see the fragmentation as well, I think, in the legislative process. when we have so many different committees that might be assigned a bill related to mental health care. And so it's hard really to track and to maintain an overall vision. Now, I was pleased to see that recently a mental health caucus was formed in the House, and that could be a vehicle for overcoming some of this fragmentation, a vehicle for promoting a kind of system-wide vision that would enable broad-based education and tracking of different concerns as they go in and out of this kind of labyrinth of legislative process and bureaucratic administration. I think that's important. You're right. If you're going to have effective advocacy, you really have to be able to watch the system at many points at one time.
And I guess, except perhaps, I mean, we can talk about Kay Khan, we can talk about a few people that are politically in the system who do have a kind of a holistic view, but it's really asking a lot to think about DSS and its mental health mission, DOC, Department of Corrections, and its mental health mission, DMA and its role in mental health coverage, DMH. Maybe we should talk a little bit about DMH. How do you see it as the lead, I forget how you refer to it in your monograph, but the lead agency for mental health issues in Massachusetts?
Well, I think of all these different agencies that you mentioned, it is the lead agency. And it's true that these other agencies care for certain populations with their important mental health needs, but it's DMH that is legally the state mental health authority. And it has the primary responsibility, I think, when it comes to so many operations within the system and for speaking out on issues within that system, too. I think what's happened to DMH over the years is a fascinating story. We have had a process of deinstitutionalization going on for 4 decades and more in the state of Massachusetts. And DMH has really had to very much change its role over this period of time from being the primary provider of services in the public sector, and these services primarily being long-term hospital services, to a situation where it would be a system would be based on community services, and DMH would provide some of those, but actually it would probably do a lot more through the contracting process. And this is what has happened, I think, over several decades, that DMH has had to undertake a change in its own personal, bureaucratic vision and its role within the system. And I think it's been a struggle. I think there are many things that have been done well. The system has moved in a good direction. But you cannot read DMH's own reports on the state of the system without appreciating that there are massive waiting lists for key services. And I credit DMH for being rather upfront in detailing both the things that it feels are its main accomplishments and the things where it feels that a much better job is necessary, because there are people who are going without needed services.
Now, let me just go back, though. You said had to. Says who? Had to shift its focus. And I'm not talking so much about the hospital to community focus as much as going from the buying to the making to the buying, the purchasing, the vendoring of services, which currently, what is about 60% of their budget, they purchase services, and about 40% of their budget they actually are administering and or providing services.
Right. Why do they have to do this? Well, it's true. Technically, I suppose DMH could have remained static in some of its roles, and in particular in the role of being the primary provider of services, even as these changed from being institutional to community services. And DMH does provide a lot of community services. But I think DMH had to change because there was a broad current of change that was sweeping through Massachusetts government and other governments as well. And that had to do with the focus on reinventing government and privatization and Governor Weld's strong agenda for change of this type. I don't think DMH really had much of an option to remain aloof from that process that was affecting so many agencies in state government at the beginning of the 1990s. The contracting actually began earlier than that within DMH. I think it has, in some ways, been effective for broadening the range of services, and it has been a vehicle in part for cost control as well, and that can be problematic if you consider some of the ways that's been done. But I think it's a larger change than just the operation of the mental health system that DMH has been responding to.
So it might be fair to say, though, that it really has been politically driven, that it was a Weld initiative to basically privatize to the extent that privatization took hold in his first administration?
Well, I think it certainly was a political choice, driven on the one hand by ideology, a belief that government should be smaller, that government could be more effective if certain things were privatized. That's a certain belief system within politics. Not everyone believes in that, but I think Governor Weld articulated that vision strongly. There was also a push at that time politically for something else, and that was cost savings. And there was a feeling that by privatizing services and by moving toward a managed care system, that there could be significant savings realized within the operation of the systems, both the DMH system and the operation of Medicaid. And so these two things were very powerful forces that came together, and I think that has largely shaped what's happened to the mental health system over the past decade.
So the DMH's role has really been, in large part, shifting to sort of overseeing the delivery of some services. Well, I guess part of my experience is that it's kind of gone halfway. The DMH trying to sort of, Bob Dorwart used the term, make or buy analysis. It's tried to sort of buy some services and make some services. And I think in trying to do both, it's ended up with a very fragmented service delivery system that in fact may be extremely costly. Yes, there was downsizing of state government, but I think the cost to direct service delivery may have been extreme. Your thoughts on that?
Well, I think the cost issue is a tricky one, and costs are difficult to track. I think it's quite clear that DMH and the Division of Medical Assistance as well have been able to save money by their movement into a managed care environment and by greater use of contracting. It doesn't mean that they've been able to save equally across the board. It doesn't mean that administrative expenditures are as low as one might want in a system that's been pared down in terms of service delivery. But I think there has been reallocation. I think to the credit of these agencies, some of that money has been reinvested. The continuum of community care services is greater now under the auspices of DMH and under the Division of Medical Assistance than it was 10 years earlier. But some of those savings did not necessarily go back into services. And there are these questions about whether the cuts that have been made had impacts on quality of care that have not been well measured and that need to be put in the balance scale when we're talking about the success of a system purely in terms of cost savings and some expansion of the continuum of care.
Okay. Well, I think this is a good point to take a break. I think before we leave DMH, though, after the break, I think I'd like to dwell on that for a moment, in part because it is the lead agency and in part because its whole approach to delivery has changed so radically in the last 15, 20 years. So thank you. We'll be back in a moment.
A log cabin on the lake. Just me and my wife and fishing.
I can tell you what I won't do. Won't just curl up and vegetate.
Do something I've wanted to do since college. Go back to college.
Eating un crucero. Alaska.
Secure your retirement plans with U.S. savings bonds.
When you think of retirement, you think no more boss, no more responsibilities, but it also means no more paycheck. So where will the money come from?
I have a pension plan where I work. But will I still be working there 20 years from now?
Start saving for retirement now with U.S. savings bonds. They're the easy way to save. They're the safe way to invest in your future. Get details where you work or bank. Or write U.S. Savings Bonds, Department of the Treasury, Washington, D.C. 20226.
Look, you work too hard not to reward yourself when you retire.
Take stock in America. U.S. Savings Bonds.
I'd like to pick up a little bit more on DMH because they're on the hook as far as I'm concerned. I have trouble these days understanding their positive role in service delivery in the community. I was very much part of the deinstitutionalization movement back in the 70s. We all got brownie points, you know, for moving people out, moving people onto the Medicaid budget so that it would be half federal, half state, et cetera, et cetera. But there are a lot of problems that have cropped up as a result of the changing role of DMH, and perhaps we could dwell on that for a moment. In vendoring services, for example, and I understand this was Wells' vision, a downsizing government, et cetera, we have really ended up with a very fragmented system of service delivery. I mean, I saw, I don't know, 15 patients today, and I will bet you that 10 of those patients are getting mental health related support services from more than 3 agencies, for example. Perhaps you could comment on that.
Well, I understand, and I can appreciate how much of a challenge that would be, coordinating the services in a situation like that. I think in part that's an inevitable outcome, though, of the way the system has changed. When you move from a situation several decades ago where you had many different kinds of services being provided under one roof, that being the roof of the state hospital, you could much more easily coordinate the services, the medical, mental health, housing services that were being delivered. When you decide that that is too restrictive a setting and that people have civil liberties and human rights that can be much more effectively served in the community setting, then you're moving into a service delivery environment where fragmentation is typical. Now, that doesn't mean that you should not identify that as a major problem, put it high on the agenda, and try to overcome it. When there are these gaps in terms of who's responsible for what patient and there's quarreling between different agencies, then I think it's quite clear that this is an issue that needs attention. But I do think it remains one of these largely unanticipated problems with the implementation of community care. That when we moved into the area of community care with rapid deinstitutionalization, and again this goes back over many decades, I don't think that the people in charge or the scholars who were studying this, I don't think anyone really appreciated the challenge that would be involved in developing so-called hospital without walls. Because I think for the most seriously ill, that is truly what they need or could benefit from. Maybe not on a permanent basis, but certainly during some stages of their illness, they need to have a kind of package of services that is quite comprehensive and supportive in a lot of ways, and no one agency delivers all those services. And so that becomes a challenge. It's an administrative challenge at that point.
Well, but on the other hand, to be a devil's advocate, and I, by the way, appreciate your citing the Mental Health Action Project, of which I was a part. I was a committee chair. Very much appreciated the opportunity that Michael Dukakis created to sort of look at the system. I think a lot of the problems could be anticipated. And really, the outcome of that study was basically to suggest that there needed to be a single point of entry in the community so that people could not so much one-stop shopping, but basically they knew where to go so that they could start to unravel how to get some of their community needs addressed. And I'm not saying that I want to provide housing and all the other services that clearly, you know, the Boston Housing Authority in Boston, for example, provides. But the fragmentation is just, it's unbelievable. H is a patient of mine, and for many years she was living in a halfway house that a number of us were able to get going years ago, and that's been her home for about 19 years. Over that period of time, the vendoring of that program has changed twice. And I think it's kind of fallen into difficult times and into difficult hands as far as the current vendor. They don't want her there any longer because her health needs have shifted as she has grown older. We're talking about 22 years that I've been following her. And she now has diabetes, et cetera, and they say, well, we don't. So suddenly they make a decision that she no longer fits their criteria. Now, what has changed over the time with each change in vendorship is a change in the criteria. So in the meantime now, she's in a nursing home rehabbing, and I'm stepping on a lot of toes to try to get her back to her home. There are at least 5 different agencies that I have to interface with, and by the way, nobody pays me to interface with those agencies. Whole reimbursement structures we may want to get into as well. But there's someone who is not doing well in the community. Would she be better off in a state hospital? perhaps not. But state hospitals don't necessarily have to have been restrictive, you know, tromping on everybody's civil rights institutions either. And Dorothea Dix had a wonderful idea. She had a wonderful vision in the 1850s. And I wish to some extent we could have some of that back today for some of our longer-term patients who might benefit from a bucolic setting as opposed to an urban setting. But how do you get around problems like that? How do I help my patient get the services that I think common sense dictates she needs?
There's a lot to respond to there. Let's go back for a minute to the mid-1980s and that mental health action project of the Dukakis administration. I think what's key about what was being proposed at that time is that it combined the notion of a full continuum of services with an increase of funding for the system, and without coupling it to a process of rapid deinstitutionalization. A lot of those services did actually appear. They were acquired, many of them on a contract basis. So in that period of time, contracting wasn't an unknown process. But I think what happened in the early years of the Weld administration is that the vision, back to that idea of vision, the vision of mental health reform was tied to the idea of cost cutting. And it's hard to expand services and to deal with some of the issues that you're discussing now when you're also trying in a major way to reduce government and cut services. I think, although I'm not an expert at all on anything approaching a clinical matter in mental health care, but it seems to me that the kind of client that you're referring to is someone who really needs to have a very effective and thorough case management service provided. And that is a major gap in the system right now. According to DMH's own figures, there are some 14,000 individuals that are eligible for case management. They want to provide case management to these people so that they can access the necessary package of services, and yet they're on a waiting list, and they're sitting there, and the waiting list is growing larger. And the same is true, not so large a list, but there is a substantial waiting list in the area of housing. So I think it's, at this point, the coordination issue is being more and more appreciated. It's never going to be an easy issue, but there are some approaches, including the use of case management. But that becomes, I think, at that point, the funding question. Are we willing to inject resources into the system to expand for the services that we believe are needed to solve the problems that have come to light? The Department of Mental Health budget, over the period of the 1990s, went from approximately 4% of the overall state budget to less than 3%. And so in that kind of a situation, it's hard to serve to meet all of the goals and objectives that you realize are worthwhile. And I do believe within DMH they have some excellent model programs. And I think they, more than anyone perhaps, have advocated the value of services like case management. And innovations such as the assertive community treatment model, which is quite ambitious in providing a whole package of services to people who are most seriously mentally ill. But these are expensive programs, and unfortunately, all the people who can benefit from them are not getting access to them. So I don't know at this point if it's so much a lack of knowledge in what's good for making the system improve as a lack of commitment, and not really within DMH. I wouldn't point the figure there right now, though they are responsible for operating the system. But they have to make use of the resources that are provided to them within the political process.
All right, but again, to be a devil's advocate, they recognize the importance of case management, actually vendored out fairly substantial contracts. Unfortunately, then they vendor them out, then a couple years later they vendor them out again, and it's not always the same vendor, a different problem. But what does DMH do? It not only vendors out a fairly complicated, sophisticated network of case management services, it then hires a whole army of DMH-employed case managers to monitor the vendor case managers. So there's a tremendous amount of duplication in the system, and I think some of it is at the feet of DMH in basically trying to vendor some and provide some. You know, they either vendor it all or provide it all.
Well, that may well be, and I think it's quite ironic, but it's true that there are problems of duplication at the same time that there are problems of gaps in services. And case management, which is supposed to be this kind of linchpin, a hub of the wheel that organizes so much else on behalf of the client, is often duplicated when you look from one agency to another. And some of the main concerns right now have to do with developing a case management process and an information system going along with that that can transcend agency boundaries. So I know what you're saying. These are truly systemic problems.
Well, and we really are in a kind of time warp where, I mean, there are a lot of programs that are vendored, and unfortunately, I think there are also too many vendors. You know, that's one of the problems, and I don't think that is of necessity. Vendors that are providing competing services, not necessarily, differentiated services, specialized services that one can't provide that the other is able to provide. So you have hundreds of vendors basically out there all competing to sort of, make their programs float, do God's work, but still, I think, meet a bottom line. And the Department of Mental Health then spends an excessive amount of money watching them all and basically waiting for some of them to fall down, too, because that's when you really hear from DMH, when there's an untoward event, that occurs. But I guess I've recently been more concerned about the role of DMH and its kind of schizophrenic stance in terms of making or buying services and how costly that is, at the expense, really, of, give me $575 million. Percentages, I understand, but the fact is their budget goes up every year. $575 million, I can take care of more than 24,500 clients per year for $575 million. And believe me, I would welcome the opportunity to give it a try. That's a lot of money, and that's only one agency.
It is a lot of money. I think it's probably not enough. If you look at the trends, we have a situation with the budget now that has several forces coming together that might be problematic. We have a slowing down of the revenue stream because of the changes in the economy right now and because of the large tax cuts that the voters were asked to approve last year. At the same time, we have ongoing increases in the health sector and Medicaid, other health programs. And as these various forces come together, it's what the Massachusetts Taxpayers Foundation calls the perfect storm situation. That there are too many elements coming together and creating a dynamic where there are going to need to be difficult choices. And I would hope that in an environment like that, that it will be seen still that DMH could benefit from additional resources because of the very long waiting lists for services. Maybe some things can be done more efficiently. I don't know. I guess I'd like to have an insider's expertise to comment on particular administrative practices, but it just seems to me that there's a scale of response here that isn't quite equivalent to the vision of community care that we had 20 years ago.
We all know what happened to the Andrea Gale. So at the end of this next break, perhaps we could pick up on really some of the policy issues and dilemmas that you identify in your report.
That'd be great.
Thank you.
In RSVP, we don't just want to change the world. We're old enough to know how.
Retired and Senior Volunteer Program is a program for people 55 and over to work in many different capacities in the community.
I worked with sixth graders, and the teacher told me that her sixth graders' scores were much higher than any of the other scores. I was delighted.
Show us a problem, a tough one. We have the skills to find real answers.
They're basically eyes and ears for the deputies.
We have a staff of 300 volunteers restoring aircraft for the museum.
When you built the plane, where did you get the parts?
We made them.
Your life experience, shared for a day, a week, a year, that's what it takes to make the world a better place. It takes you.
Maybe we could talk a little bit about some of the policy issues and dilemmas that you identify in your report as we try to move a little bit beyond specific roles of different agencies
Sure.
to some of the problem areas?
Well, you know, I think there's a lot of issues touching different sectors. Homelessness remains an important issue. I think the estimates are that there's more than 9,000 homeless people in Massachusetts at this point. Approximately 2,000 of them are considered to have major mental illness. Maybe 2/3 of that group simultaneously have substance abuse disorders. And this is a population that is not decreasing. And again, there are some, you know, in this area, as in so many of the other things that we can talk about, there are some model programs. It's not that there hasn't been an attempt to set up good services with outreach and referral to a variety of different kinds of supports, whether it's housing or you know, employment training and things like this. That's out there, but it's certainly not enough. It's not reaching enough people. And so what you have is a very overstrained shelter system. And you have, unfortunately, many seriously mentally ill people rotating in and out of the shelters. And it's not a good situation for them. Clearly, it's not a good situation for society in general. I think it's a kind of a chronic, it is a chronic problem for the system that we haven't really done enough about.
And by the way, may I interject, I was part of the lawsuit as a consultant that the Pine Street Inn brought against the Department of Mental Health to obligate the Department of Mental Health to provide services to discharge patients who ended up in shelters. And the mayor of Boston joined the suit, and they had very good legal representation, and they lost. The Department of Mental Health fought the suit and basically won.
Well, sometimes the legal process is often unpredictable, and yet I think it remains a crucial one when you look at the kinds of changes that are sought. In Massachusetts, it has already performed an important function in providing a stimulus for actions like the deinstitutionalization of Northampton State Hospital with the consent decree there over the years. I think right now there's talk about perhaps a suit forcing the state to improve services for children. I think it's a source of leverage potentially. It certainly is a way to sharpen the focus on an issue and to point out some of these chronic problems, because, as I say, these are not secrets. You know, the long waiting lists are well documented. They're there in the annual reports that DMH and some other groups put out, and the legislature certainly gets a chance to see these things. But I believe over time we become numb to them, and it becomes acceptable, and we fall into a mode of incremental expansion of the system, incremental improvements in funding. For example, that recent additional $12 million that was put into the DMH budget. These things are a help, but again, I think they're out of scale with the situation that we're describing. And so I think as we consider the issues like homelessness, the ongoing needs for community support, and children's mental health services, clearly there needs to be more energy and a sense of doing something, I believe, that's beyond the usual incremental solutions, which are no solutions at all. They're merely Band-Aids.
Well, I think children's services, I mean, you just have to read the local papers to know what a crisis that is. But again, from a direct, you know, from the trenches, I think I told you before the show, every time one of our child psychiatrists sees a patient, we probably lose $50. There ought to be a way that the department, and that's because of managed care and the rates of reimbursements that have been agreed upon. Unfortunately, those rates don't begin to approximate what the costs of service delivery are. Now, years ago, you agreed to those rates or you weren't a player. So the New England Medical Center, the institution I work for, but you know, everybody signed up. They figured they might as well be in the tent as opposed to outside the tent.
It's tough to be outside that tent.
That's right. On the other hand, it's very tough to be inside the tent, knowing that every time you provide a needed service, you're going to lose a certain amount of money. Never mind that the child psychiatrist would be there, the patient doesn't show up, you lose that as well. There's no risk sharing when it comes to managed care. Other problem areas that you've identified?
Well, maybe we should talk a little bit more about the children's area, because I think it's such an important one. I know so many families struggle with really tragic situations sometimes, attempting to get services that they need. I think here it's quite clear we have a problem that is emblematic of a system that is out of balance, that is not a complete system with respect to the continuum of care. there are somewhere around 100 children, I believe, who are stuck right now in hospital beds, psychiatric hospital beds, excuse me, within Massachusetts. Not because they need to be there for their medical or psychiatric reasons, but because what they really do need is not available to them. Meanwhile, there are patients needing those beds who are lined up in other settings of care, sometimes in other hospital units, which are inappropriate for them, and they can't get access to the services they need because of this bottleneck in the system. Now, it's the kind of problem which at least has been getting some major media attention. And in the city of Boston recently, there was a summit called among key players in different systems affected by this to discuss the problem. So I think there's quite a bit of visibility to this right now. And one might say about time. You know, this has been a situation that's been brewing for a couple of years at least. And I think what it does reflect is in part what you've just referred to, that there is an inadequate reimbursement structure. And when that happens, the continuum of care does not develop in the way that's needed, both pre and post-hospital. And so now I think it's probably well recognized that there needs to be some consideration given to how to boost or further develop the infrastructure of services, both pre and post-hospital, or as alternatives to hospitals, within the children's mental health system. And that's going to, I think, require better reimbursement for practitioners in different settings. It may well require better rates of pay for the mental health workers who are in these vendored agencies. That's a major concern right now, too. So I think you can only go for so long underfunding a system and hoping that people will make do with the services or the resources provided to them. There comes a point where supply and demand don't meet any longer, and I think we're at that point within the children's mental health area.
But don't you think at some point the legislature gets a little tired of constantly being told that it needs to put more money into the system? I mean, I told you earlier that I have the luxury of a small grant to study where current monies are going. If I were a legislator, I'd be very interested in first knowing where is money going that is currently in the budget.
Well, I think that's true. I think that's true, and I think there probably has not been adequate monitoring of the for-profit managed care system that's now set up here in Massachusetts within the Medicaid. It operates on behalf of both Medicaid and DMH for its acute care services. I think it's true that there are issues raised as to the administrative aspect of the payments going to that agency. You know, how much is enough? What's a fair rate of pay for administration? What about the various incentives that are given in contracts for doing this and that?
Or not doing this and that.
Well, there's all kinds of incentives there, and sometimes they're confusing. It's an important question. I hope I know that research that you've spoken to me about will delve into this. I think trying to find the right way to examine this, it's not so much, I think, that you're comparing maybe what a for-profit company is doing compared to what DMH was doing. These are very different kinds of entities. I think it's trying to find within this managed care and privatized environment, what are the standards, what are the proper comparisons to make across different companies, across alternatives, maybe nonprofit versus for-profit, that tell us what is the right administrative support that should be going to the system and how much really needs to be guaranteed to be going for services. I think that's a crucial question. There have been complaints about the level of monitoring of this so-called carve-out contract to the for-profit provider. It has improved over time. There are more demands in the area of data requests being made all the time of this for-profit provider. The reports, I gather, are still rather scanty, not always on time, and maybe not designed in such a way that they get to the key issue of what is quality and what are the outcomes under the system. To some extent, they respond, I think, to questions of efficiency and processing paperwork, and that can't be all that these reports are about. But I think it's been a learning process and somewhat painful, I think, for maybe some of the families who have not benefited from the way the system was run. But a learning process in which the state, both the Division of Medical Assistance and the Department of Mental Health, are trying to improve their supervision of the contracting process so that they get more information relevant to an evaluation and of this whole process, and that would be very helpful to legislators as well. I don't think it's going to solve problems. I think still we need to expand some of those services that are out there that are incomplete.
A philanthropist I know very well, he and I were talking, and his estimate is that at a minimum, 50% of all the money is lost to administrative overhead in its many different forms.
Not just in mental health, but in
in mental health.
In
No, he's talking about mental health programming. That for every $2 allocated, less than $1 actually hits the streets. And I've been intrigued by that, as you know, because if that's the case, then there really are some fundamental flaws within the system that ought to be addressed while the legislature is also asked to kick in more money for other needs.
Well, again, it's difficult to know how much is enough because good administration costs money. Putting together the new kinds of data systems that managed care requires costs money. So there has to be an adequate administrative payment. Not to make an adequate payment in that sense would hurt the system in various ways. But I think what needs to be dealt with is the irony of a situation where you can have further deterioration of the system in terms of we're talking about children waiting in hospitals when they don't need that. They need some other kind of care. Or when you have growing lists of people needing case management and housing services. How can you have a system which by certain measures, I don't want to say deteriorating, that's rather strong, but is certainly under increasing strain, and by certain performance measures is struggling to even maintain its existing level of performance? How can you have that be a situation that's in existence and yet have a primary for-profit provider being judged to be rather successful in the way that it's running its program? It seems to me that's the mismatch. There has to be a system-wide recognition and performance targets tied in various ways among various activists and agencies in the system that reflects when the system is not doing well. We should not be surprised by a crisis because we've been evaluating a contract and then everything seems fine within that contract, and then suddenly there's a crisis. That seems to me very odd. There just needs to be a way of linking together different components of the system and measuring outcomes so that we can identify the main problems and move resources to those problems. If that takes administrative payments and it's effective, I don't think people will object to that, but people want to be sure that they're getting the results.
Right. Well, let's take a break, and then perhaps we can look at some of those structures that might help promote services and yet assure quality. Okay.
My Youth for Understanding experience was the best thing I've ever done in my entire life.
If you want to learn a language, this is how you do it. You have to live here and you have to breathe in the country.
You meet a whole new family that are willing to accept you and take you in.
I feel just like I'm a part of the family. Being involved with the family, living right at home, that has been my best learning experience so far.
You only live once, so you do it, try it, live it. It was great. It was incredible.
Go global.
Okay, we are 4 decades later. We've all bought into the deinstitutionalization. I think now many of us are sort of struggling with providing quality services in a community locus, or at least in the least restrictive alternative locus. Your thoughts about sort of how can we provide quality with the proper degree of oversight?
Well, I think, it is interesting to look back over 4 decades and to consider how much the system has changed. And I think it's tempting to use that as a base to look ahead another few decades and fashion some hopes about where the system might move. I think one of the things that one would really hope for in the future is to expand insurance coverage. We are still at a situation in Massachusetts where there are many people, maybe as many as 10% of the population by some estimates, who lack insurance coverage. Within the mental health area, there are still many people who are underinsured for that particular area. And so this is a situation that I think one could hope would be dealt with and expanded in the years to come. A very important piece of legislation passed in 2000 to bring about partial parity in the mental health area. But it was another one of these incremental steps. It was not an easy step to take. This is something that's been debated within the legislature for many, many years. There are powerful interests who were worried about the cost of this kind of action, that is expanding insurance coverage for mental health care. And yet finally there was action taken. But as I say, it was a partial parity measure that is responsive primarily to the needs of individuals with what are thought to be biologically based disorders, and as well to children who have mental health problems that impair functioning and activities. And it's certainly worthwhile and something to be celebrated that these problems were dealt with in that legislation, and yet it leaves other groups still uncovered.
See, let me interrupt. See, there's a problem, because I think the public has a problem paying attention to these problems long enough to really then stay with it to the point of a solution. The parity bill, I think a lot of people have said, terrific, now we can move on. The parity bill created more problems than it solved. I got a very threatening letter from one of the companies saying that the good therapist, I'm paraphrasing, a good therapist needs no more than 12 sessions a year. So we do not think that most of our panel will need more than 12 sessions a year to cure all their patients.
Mm-hmm.
Basically suggesting that they were going to profile me. And if I ended up, even with the brain diseases, which presumably you have unlimited number of sessions for the 9 brain diseases, the 10th being other.
Right.
We all have other, I guess. But it was very clear that they were going to approve 12 sessions, which isn't different from the pre-parity bill days.
Right.
And not expect me to then come back to them with requests for further service.
Well, I think you bring out an excellent point, and that's how sometimes issues interlock in ways that are not maybe well dealt with.
Mm-hmm.
Parity, I think it's an important piece of legislation. I think it's incomplete, but I do think it's an advance. It's one of these incremental steps. And yet a key question is, how important is parity, that is the benefits that it creates in law, theoretically, when one's access to these benefits is still very much controlled by the gatekeeping process of managed care.
Sure.
And so what I think this indicates is that you not only need parity, you need to have vigorous regulation of managed care to go along with parity. We have also passed in the state in the same year, in 2000, a new managed care regulatory bill. I think it remains to be seen just how focused that will be on the needs of mental health consumers. But I think this is a critical issue, because having benefits theoretically when one doesn't have access to them in practice because of the practices of managed care gatekeeping is not satisfying. It's not bringing us to the goal that was intended by the advocates for these measures.
Would you be surprised if I told you, again as a direct service provider, I told you that in fact one of the worst things that can happen to some of our patients is for them to lose Medicaid and get private insurance secondary to employment? Because then their access to care goes from an easy 26 visits by simply calling a computer, so here I'm giving the partnership high marks in the outpatient setting, to a complicated system where they might get 8 to 12 visits approved. Then, depending upon, quote, medical necessity, a reviewer on the other end of the telephone has to be convinced by me that the problems are sufficiently medically necessary, or the services are medically necessary for the problems described. So I have to keep giving more and more information away to finally convince the examiner that in fact, well, additional visits, and even then nobody's yet had any experience about how many additional visits they're going to provide at a time. Most of them are giving 8 to 12 January 1st. Terrific. But we're only, I think, now in that time of year. when we're going to be able to test the parity bill by seeing, in fact, how many companies are going to, in fact, read the law, keep the co-pays the same as they are for medical visits, which is an important piece of the parity bill, and then, in fact, make access for people who have the brain diseases generous.
Right. Well, no, I'm not entirely surprised to find out that Medicaid, in some ways, is a much more generous and comprehensive program when it comes to mental health care.
Outpatient, yeah.
Outpatient and perhaps also inpatient in certain circumstances. I think to reflect on that for a minute is worthwhile. It shows that managed care does have certain benefits. Doesn't mean that it's providing necessarily quality care across the board. It doesn't mean that there hasn't been an excessive reduction of hospitalization, but there is certainly a broader range of services, diversionary services and emergency intervention services of various types that are existent under Medicaid now than you will find in many private plans. So what do we have then? We have a system where if you have private insurance, you need to be able to rely on the gatekeepers. You have to be well informed about how your plan operates. You have to be well informed about how do you make appeals, both internal and external appeals, if it comes to a situation where you feel that you are being denied needed treatments. Now, these opportunities do exist to appeal these kinds of decisions, adverse treatment decisions, but you know, sometimes people do not really have the savvy, or they're not in a situation when they're in the midst of a mental health crisis that will perhaps enable them to take advantage of these options effectively. But I am hopeful that with the new Managed Care Oversight Board that was created with the Managed Care regulatory legislation in 2000, that as more of these issues come to light, then there will be more attention to making sure that people have access to needed benefits.
Well, you know, maybe I'm too jaded, and I certainly am delighted that you're hopeful, and I guess in the remaining few moments that we have, few minutes, perhaps you could talk a little bit about where you think we'll be 3, 4, 5 years from now in terms of addressing some of these issues.
Well, it does seem to me that looking back over the past decade, that the mental health system has been shaped largely by forces that are outside of the mental health system, that are larger than the mental health system. When we talk about privatization, we talk about the arrival of managed care, we talk about the great increases in healthcare costs, which have pushed for a response of healthcare cost containment. All of these things impacted quite importantly on mental health and the decision makers and how they directed that system. I am concerned that over the next 10 years it's going to be a repetition of that pattern, where what's happening in the economy. Are we heading into a situation where, because of the tax cut and the slowdown of the economy, will that tighten up the budget in such a way that it will impact on mental health? Hold it where it is when it needs to grow, in my opinion. I think we're going to see that probably. But if I can remain hopeful, if you let me be hopeful,
I love it.
then let me point out something that I think is certainly true about the mental health system. And that is, if you take a long view of that system, that it has operated in terms of cycles, that there have been long periods of sometimes neglect, sometimes just status quo within that system, and you think there will not be a breakthrough of interest. And then suddenly forces come together that do push the mental health issue quite to the top of the political agenda. This has happened several times. It happened in the original community mental health revolution. We talked about the Mental Health Action Project in the mid-1980s in Massachusetts. I think there are conditions, often it's a sense of crisis, and that's too bad. Often that's what it takes. But there are conditions that can come together that can supercharge the political process, so to speak, on this issue, and allow for the policy direction in the system to overcome things as usual. So I would remain hopeful that perhaps there'll be a breakthrough like that, as maybe effective spokespeople appear to push for the issue, and as there's a greater recognition of the seriousness of situations like children's mental health care, what we see in that sector right now. I'm hopeful about that. Otherwise, I think it is a system that is not politically powerful and as such, it will primarily be reactive to larger political trends.
Mm-hmm. Yeah, I think that's important. We have a couple minutes left. Why isn't the system more powerful, or why isn't the advocacy community more successful?
Well, I think you mentioned this early in our conversation, that we have a lot of advocacy groups, a lot of interest groups interested in mental health care, but they have often narrow concerns. We have people who are interested in those with the most severe mental illnesses, those who are interested with children and their well-being, those who are more interested in the idea of a broad-based educational aspect to this. So there's all that. Then you have providers, you have hospitals, and you have psychologists and psychiatrists. You certainly do have enough players who are interested in the fate of the system and in its performance, but they often need and want different things, and so they haven't coalesced effectively, I think. I think the way the legislature deals with mental health issues is, as I mentioned earlier, often very fragmented. And I think in general, we need to think about the fact that there is a lot of societal stigma attached to this problem. And unless you're in a family that is directly affected, as you have a family member, you yourself, or maybe someone close to the family, who's had difficulty because of mental health problems, it's not something that you're likely to interest yourself in and speak out on. And even sometimes when you have had something like that touch close to home, you're reluctant to speak out because of the stigma. So I think for all those various reasons, there are several strikes against mental health care as a political issue, and yet at times it does transcend these conditions, and things do happen.
Well, let me tell you, I appreciate you being here today. I especially appreciate your hopefulness, and I will borrow from that. So on behalf of the Norfolk Alliance, I want to thank you for being here today on Mind Over Matter. Thank you very much.
Thanks for inviting me.